Welcome back, DDS3, to another wonderful week of online asynchronous learning. Today we're going to be talking about the principles of management of impacted teeth. So what is an impacted tooth? So an impacted tooth specifically is one that fails to erupt into the dental arch within the usual range of expected time, as opposed to an unerupted tooth, which includes impacted teeth and teeth that are in the process of erupting. What causes a tooth to become impacted? It could be one of many things. It could just be the adjacent teeth blocked it out. You see this all the time with upper canines. It could just be dense overlying bone, excessive soft tissue, genetic abnormalities. All of these things can contribute to prevention of eruption of a tooth within the normal time frame. So typically the teeth that are the last to show up at the party are the ones that get blocked out and impacted. So in the maxilla, the most common is the maxillary third molar, and in the mandible, it's the mandibular third molars. After wisdom teeth, typically tends to be maxillary canines and mandibular premolars for the similar reason. So in the maxilla, the canine typically erupts after the premolars. So if there's not much space, the incisors and the premolars are going to use it all up, blocking out your canines. And in the mandible, the premolars usually come in after the canine. So once again, they tend to be the ones that get left out and get impacted in the mandibular arch. So let's look at third molar specifically. The average age of completion of the eruption of the third molar is about 20 years. So important numbers to have in your head. That typically the crown has been fully formed by 14, and then typically the tooth is fully formed and erupted by 20. But certainly third molars will continue to move up until the age of 25. So point is, if you see your patient at 14 and just the crown's developed, you say you're right on track. And then if you see them at 20 and it's not erupted and it's not probable and there's no problems with it, that's not a good reason to leave it. That tooth's going to continue to move, slowly erupt, cusps will come poking through up until 25, 26, and we see that all the time. So best thing to do is send them for consultation. Certainly anytime 16 on is a very reasonable time to come up with a plan to take them out before they become symptomatic. What do you want to send them at 16? Once again, 16 being sort of an average. If the patient's dental development is ahead of schedule, then certainly send them sooner. But what's the motivation? So the idea is to get them in there for consultation, knowing that early removal reduces post-op morbidity and allows for the best healing. Younger patients just tolerate the procedure better and recover more quickly, less interference with their daily lives. The big thing is periodontal healing is better in younger patients. They have more complete regeneration of the periodontal soft and hard tissues distal to the second molar if you do it certainly when they're younger. And also recovery is better if you are to bruise the inferior alveolar nerve. In general, the procedure is quicker, which leads to decreased pain and swelling when the patient's younger, just because the roots aren't fully developed. The bone's less dense, there's more PDL space. It's just night and day easier to do when the patient is sent in at the appropriate age. 16 to 18 is sort of ideal. Certainly less than 25. Biggest thing correlated with post-op pain and swelling is length of surgery. So if you send them in when they're 25 and they have these little tiny hooks on their roots, and you're picking away at little root tips for an extra 10 minutes, and you just doubled the time of the surgery, it's overall disservice to that patient. So send them 16 to 18 is ideal. So if you send them in for consultation, say sometimes sort of 16 to 18, then you can tee things up to do it typically anytime after that. But if you send them in when they're 16, you can often tee it up to do it that coming summer when they're 17 to 20. It allows you to get the wheels in motion. They can sort of organize their life to rearrange their schedules to accommodate having the minor procedure done. But once again, these are sort of average ages. I've certainly taken out wisdom teeth on patients as young as 12 years old because their dental development is way ahead of their chronologic age. So at the end of the day, less important to look at the age and more look at the teeth. So the ideal time for removal of impacted third molars is when the roots of the teeth are sort of 1/3 formed, and therefore they're 2/3 formed overall with respect to the tooth. So you have the crown plus 1/3 of the root. This is usually, I say, during that mid to late teenage years. So ideal time to actually take them out, going to be different for every patient, but often I say if you send them for a consult, sort of 16 to 18, then you can actually get them out sort of 17 to 20. My personal favorite age to take out wisdom teeth is 17, 18. I just feel that it's that perfect balance between the patient's maturity, tooth development, and it's still quite easy to do. So if I were to pick one age to take out wisdom teeth, it would be 18 years, all day, every day. Other surgeons may prefer younger, closer to 16, but my personal preference is 18. I just find people tolerate it really well, and the teeth still come out really easily. The patients are just a little bit more mature at that point, and everybody seems to do better. This is my big pet peeve is we miss that window of opportunity and we wait until dental caries, periodontal disease, root resorption, cysts, tumors, sending patients in when they're 25, 28, 35, 45. You just wish you could get in a time travel device and go back to when the patient was 16, 17, 18, when the teeth were asymptomatic, smaller, less developed, and so much easier to take out. It is not the same surgery, just later in life. It is much harder. So do your patients a solid and send them at an appropriate time for a consultation to discuss their options. Here you can see the third molar of a patient that didn't have the luxury of a consultation or chose not to go ahead, and untreated, of course, developing severe periodontal bone loss in the distal aspect of their lower 7. Looks like about 50% bone loss, plus or minus some caries developing there. Just a nasty situation that's totally avoidable. More examples of the same thing. So like I mentioned, if it's done when the patient's younger, certainly the studies will use the age of 25 as a cutoff, but it's a continuum. The point is younger is better to a certain point. You don't want to be sending your patient in at 14 when the upper third molars are super high. It's counterproductive. It's actually harder to do at that point in time, but you don't want to wait till they're too old because the factors associated with periodontal healing distal to the lower 7s are the extent of the preoperative bony defect, as well as the patient's age at the time of surgery. So these studies certainly show that less than 25, they'll do better than older than 25. So once again, do it when they're 18. This makes me cringe when patients come in with this situation. Once again, totally preventable, and that's why I advocate that for most people, third molar removal is a tooth sparing procedure. So this patient's going to need to have the 7 and the 8 removed. So now they're losing 2 teeth in this area, an area where they would have never developed caries had that third molar not been there or was taken out in a timely fashion. More of the same, more cringe. Pericoronitis, so inflammation and infection of the soft tissues overlying that partially impacted third molar is sort of a classic clinical presentation of this. Bound to happen. It typically gets worse with each episode, so it's not one of those things that you clear, you treat with, of course, antibiotics, and you're good to go. It might settle down, but this is an absolute ticking time bomb. It's pericoronitis, typically caused by streptococci and a large number of anaerobic bacteria. It can present anywhere from a mild infection to a severe infection that needs to go to the operating room for extraoral incision and drainage and IV antibiotics. So this would be an example of obviously a severe infection secondary to pericoronitis involving the right lateral pharyngeal space among other spaces. Looks like submandibular, buccal, and it's heading up towards infratemporal as well. Highly preventable. Like I said, it will never really go away unless you remove the source. So source control, just like most of the things that we do in dentistry, is imperative. Operculectomy, wildly unsatisfying. It often grows back. There's soft tissue covering it for a reason. There's often the tooth is sort of posterior partially in the ramus. You cut it off and then it just starts to grow back the day you cut it off. So it's very commonly ineffective and just turns out to be a big waste of surgery. So you might as well do them a solid and make arrangements to have the third molar removed definitively, and then you won't have to keep chipping away at the operculum. Root resorption, another terrible thing that can happen with impacted teeth. It seems to be fairly variable when this occurs, but certainly when it does happen, quickly creates a hopeless prognosis for the tooth that's being resorbed. And this can happen with third molars resorbing sevens, but can certainly happen with impacted canines resorbing permanent laterals as well. The exact mechanism by which this occurs isn't fully understood, and I say it tends to be fairly variable, and luckily not that common when it does occur. The mechanism is thought to be similar to the process of a permanent successor tooth resorbing a primary tooth. Unfortunately, in this scenario, it's often a permanent tooth resorbing a permanent tooth. Odontogenic cysts and tumors certainly can occur in conjunction with impacted teeth. Luckily, they're fairly rare. When you look at a radiograph or a Panorex, the dental follicle space should be less than or equal to 3 millimeters. When it gets bigger than this, it could be something known as follicular hyperplasia. But once it's bigger than this, it's worth biopsying to rule out cysts and tumors such as dentigerous cysts, odontogenic keratocysts, also known as KOTs, and ameloblastomas, all which originate from tissues in the dental follicle or the space below it, so the reduced enamel epithelium or the stratum intermedium. Not the best x-ray, cropped off section of a Panorex, but certainly showing a small dentigerous cyst associated with the EJ and distal aspect of impacted tooth 4-8. Left unchecked, it can turn into something like this. So this would be a massive dentigerous cyst. At least that's what the textbook said. This radiographically certainly seems like it'd be more in keeping with odontogenic keratocyst. In any event, it's worth picking up something like this when it's smaller, like when in the previous radiograph, compared to when it's massive like this. Obviously, much harder to treat. And this is an example of a lesion which turned out to be ameloblastoma associated with impacted third molar 3-8. Orthodontists will often request that we extract the third molars to facilitate their orthodontic treatment plan if they're distalizing the second molars. They simply need the space. Impacted teeth under a denture, you could evaluate this in a case-by-case scenario. Which tooth, how close to the oral cavity, how healthy is the patient. Certainly in some scenarios it absolutely makes sense if you're quite certain it's going to erode through underneath the complete denture. in the fairly near future, it makes sense to remove it prior to fabrication of the denture. Other times, if there's no sign of it, it's fairly deeply impacted or the patient's unhealthy, it's best to leave it alone and deal with it if and when it becomes a problem. Not so great indication is treatment of pain of unexplained origin or prevention of jaw fractures. We see people with broken jaws with third molars, without third molars, with previous plates from previous fractures, all variations. The best way to prevent a jaw fracture is not go to Pizza Corner after the bar at 4 in the morning. Let's be clear, Pizza Corner is absolutely worth it at 4 in the morning. Contraindications for removal of impacted teeth. So contraindications for anything when risks outweigh the benefits. Advantaged patients too unhealthy to undergo the procedure. Risk to adjacent structures. So the first and the last sort of go together. If you feel that the risk to the adjacent structures, namely adjacent teeth, maxillary sinus, or more commonly the inferior alveolar nerve, is such that outweighs the benefit, then that would be a reason to consider not doing the procedure. If you think you can't take out the tooth without damaging one of those above mentioned structures, that would be a scenario where the risks outweigh the benefits. Luckily, that's quite rare. Here's a good example of where the risks outweigh the benefits. So, older patient, third molar in quad 1 is deeply impacted, will likely never see the light of day. So, absolutely okay to go ahead and make upper and lower dentures here and leave a tooth like this. Certainly, as your patient starts to get a little older, certainly older than 30, we have a real hard think about whether they should be undergoing a preventative extraction of an asymptomatic disease-free third molar in that scenario. And to use that term asymptomatic disease-free, because it's perfectly acceptable to take out a asymptomatic disease-free third molar, certainly in someone less than 25. I say, like we mentioned, best to send them in sort of 16 to 18, plan to do it. The surgery, somewhere between 17 and 20, but at the end of the day, you're going to assess the actual tooth that's in front of you. Less important to be stuck on the age, more important on the tooth development. So once you get a third of the root development, perfect time to wiggle that guy out of there. So this is how I like to diagnose wisdom teeth. I didn't invent this. This comes from Dobson, which was an article in the Journal of Oral Maxillofacial Surgery 2012. It was in the proceedings of the third molar trials, and recommends diagnosing the teeth using this very simple grid. So are there symptoms present or absent, or is there disease present or absent? So if there's evidence of disease present, we'll talk about what that is in a minute, and presence of symptoms, so this would be like your pericoronitis tooth, where you look in, you see inflamed gum, the patient said, yes, it hurts. That's sort of your A. Those are no-brainers. Everybody wants those teeth out. The presence of disease but no symptoms, that would be like your, carious, partially erupted wisdom tooth. So it might not be hurting the patient yet, but complete no-brainer, needs to go. When you get into the scenario of a symptomatic tooth that you can identify any disease, you don't see any periodontal disease or any caries, a little bit more tricky. As long as they're in that younger population, 25 or less, it's reasonable to consider extracting it, simply because you'd be considering extracting it if the patient was symptomatic or not. And certainly you will hear patients sort of describe what are almost like teething type symptoms. It's just under the gum, and it just creates this gnawing kind of discomfort and pain, and they will report resolution of that, once it's gone. So a bit more of a tricky classification, but not one you run into that often, as opposed to the D category. So that's your disease-free asymptomatic third molars. And I say those are your young, healthy Wizzies with the 1/3 root development that haven't poked through yet. And technically, I diagnose them as disease-free asymptomatic third molars. I have zero problems doing them because the majority of them will eventually become one of these other categories. So instead of prolonging the inevitable, I'm putting them in a higher risk category, a category that's going to take longer to heal from and never will heal as nicely. Wiggle them out while they're in that disease-free, asymptomatic third molar category. But this is how I like to break it up in my head, and will often document them as such on the chart. Instead of just saying third molar present or absent, we can actually diagnose it based on symptoms and disease. So symptoms, typically your pain. Disease, we use that term as an umbrella term to capture your dental caries, your pericoronitis, radiolucent lesions, internal resorption, or probing depths, deep probing depths on the distal aspect of the 7. So greater than or equal to 4 millimeters at the distal aspect of the 7 is another indication that the tooth sort of has an unmaintainable pocket, disease present situation. So this would be a perfect time to wiggle out wisdom teeth such as this, where you can see it's about a third of the root development. And then you can expect reasonable bony fill, periodontal healing, like you see in this x-ray. Instead of leaving it and doing nothing, which can rarely result in something like this, which would need to be biopsied, but certainly is either a dentigerous cyst, an OKC, or an ameloblastoma. We're talking about risks versus benefits earlier. Certainly to minimize risk, anytime I have a patient who on Panorex, you can appreciate that the root is completely crossing the inferior alveolar neurovascular bundle. We'll take a CBCT just to find out where that bundle is. Is it buccal? Is it lingual? Is it sort of trapped within the roots? When you see the roots open with a nice furcation like this, it's impossible for those roots to be trapping it, but sometimes those root tips will actually come together, and rarely that inferior alveolar neurovascular bundle can actually travel through a ring created by the roots of the third molar. So you'd want to know that scenario exists before you get in there. So by getting a quick CBCT, I can tell then whether the nerve is buccal or lingual. That way, if I'm using my 701 burr, drilling around one of those roots, I know where the nerve is and where it isn't, and of course I'll choose to drill where it isn't to free up that root. So this is our CBCT machine at the end of the hall. You'll all see it when you come over for your rotation to the hospital. And quite quickly, you can certainly appreciate that inferior alveolar neurovascular bundle is sitting just to the lingual aspect of this impacted third molar. And this is a super helpful way to minimize risk. That way, if and when I'm trying to retrieve one of the roots of this third molar, I know where that bundle is so I can avoid it. Classification system for mandibular third molar impactions. Admittedly, not something I formally go through on a case-by-case basis, but certainly something that is clinically relevant in that I will sort of informally be assessing these things, and just where in my position where you've done so many, you'll just intuitively look at that tooth and say, well, it's going to be easier because it's closer to the occlusal plane in mesioangular versus one that's back in the ramus, horizontal and down really far. So it's certainly a lot of it is very intuitive, but good to go through certainly at your stage and quantify the difficulty with respect to height of impaction, angulation, and relationship to the ramus, just so you fully appreciate what it is you're seeing, and understanding why it is that you're potentially making a referral to a specialist to manage it. So starting with mandibular third molars, we're going to be looking at angulation, relationship to the anterior border of the ramus, and relationship to the occlusal plane. So this would be very common impacted wisdom tooth and a mesioangular orientation. The angulations, of course, are in relationship to the adjacent 6th and 7th. This is a horizontal angulation and is obviously a little trickier to remove than the mesioangular. The vertical orientation of impacted third molar, and tends to be a little trickier than you anticipate to get out compared to the mesioangular and the horizontal, in fact, which are relatively straightforward. Distoangular certainly are quite tricky for multiple reasons. One, the tooth is angulated back into the ramus, so it's tricky to take out because as you're elevating the segments, they're going up into the robust bony structures of the ramus. So there's not a whole lot of places to take this tooth. And the other reason I think is just because at first glance at the x-ray, a lot of distoangular teeth, almost appear a little more vertical. And when you actually look at the angulations of the 6 and 7s, then you'll realize it is distoangular. So you kind of go into them a little bit with your guard down. Compared to horizontal, you look at it and say, oh, that's impressive. It's completely sideways, and you make a big flap and good bone removal. With distoangular, they can be a little more sneaky, sneak up on you, and you have your guard down, and maybe you don't make as big a flap, and then you get into it, and you realize this is really tricky. So certainly the experienced clinician will appreciate how difficult a distoangular is right off the hopper, and really maximize all those variables: flap, design, size, bony removal, and nice clean sectioning of the tooth, appreciating that distoangular lower third molars are quite tough. Relationship to the anterior border of the ramus is another variable. Using this Pell and Gregory classification, class 1, the third molar is completely anterior to the anterior border of the ramus. Class 2 will be typically halfway back into the anterior border of the ramus. In class 3, the entire third molar is embedded posterior to the anterior border of the ramus. As you can appreciate, 1, easy, 2, a little more difficult, and 3, much more difficult. So for relationship with the anterior border of the ramus, Pell and Gregory use class 1, 2, and 3. And then for the position with respect to the occlusal plane, they'll use class A, B, and C. A being at the occlusal plane, B being somewhere between the occlusal plane and the CEJ of the adjacent 7, and C being at or below the CEJ of the adjacent 7. Obviously A being easy, B being a little more difficult, and C being much more difficult. So then you'll combine the 3 variables we discussed: angulation, position to the ramus, and position to the occlusal plane, to come up with the overall difficulty of an extraction. So a mesioangular lower third molar, that's class 1 ramus relationship, and class A depth is going to be fairly easy, as opposed to a horizontal impaction with class 2 ramus relationship and class B depth. I wouldn't try this one at home or in the oral surgery clinic at Dalhousie. This is a straight up referral. Don't even think about it. Refer it to OMF. Other factors to consider besides what we mentioned above, certainly the age and development of the tooth are going to affect the PDL space, the size of the follicular sac. The younger patient's going to have less dense bone. Root development and morphology do play a big role. Certainly conical root morphology is going to come out much easier, even as the patient's older. If you look and see a nice little sort of ice cream cone-like root, it's going to come out quite easy compared to a patient with dilacerated roots, big curved roots, extra roots, always going to be more tricky. Contact with the second molar, certainly if they're an intimate relationship between the two, one superimposed on the other is going to be much more difficult compared to if there's a nice spacing, allowing you space to get your instruments in between the teeth, space to use the drill in between the teeth if needed. And certainly the relationship to the inferior alveolar nerve. If it's crossing that nerve, like I said, your index of suspicion is low. You want to make sure you don't damage it, cause any kind of permanent injury. So I'll get a CBCT to find out exactly where that structure is at, so that I can have an educated discussion with the patient about the relative risks. So here we have a 3-8, which is mesioangular, class 1, so anterior to the ramus anterior border, and class B, so it's between the occlusal plane and the CEJ. But certainly some things working for us here. Nice conical shaped roots. Look like they're fused together the whole way, so this is going to come out much more easy compared to the tooth on the next slide. So we got horizontally impacted tooth 3-8, which is a class 1 as well, but is also a class C with dilacerated roots, so it's going to be much more difficult than on the slide before this. So a younger patient always going to have more PDL space. You can see on the mesial aspect of this mesioangular third molar, quite a nice wide PDL space. And then at the distal aspect of the crown, that follicular sac is sort of resorbing away as that tooth's trying to erupt up through, giving a place for this tooth to go as we extract it. So much easier compared to a tooth with no space and bone all around the crown. These next two slides are, I'm going to let you read them on your own. It's all true. It's all fantastic test material. Looking at maxillary teeth now, certainly going to look at vertical position of the third molar, and this is why I say I don't like to take these out when the patient's too young, because as they get a little older, 16, 17, 18, that upper third molar decreases in its vertical height, just gets closer to the oral cavity, and it's easier to wiggle out. Easier means less time means less pain and swelling. Everybody's winning. Buccal versus palatal. They're almost always buccal, but certainly every now and then one will come in that's on the palatal aspect, so it needs to be on your radar. And of course, we're always looking at the structure and position of the maxillary sinus. They're often very close to one another, but certainly needs to be looked at in each and every case. Like the other third molars we were talking about, we're always considering PDL space, size of the follicular sac, density of the surrounding bone, which typically correlates with age, and contact with the second molar. The ease of extraction in the maxillary third molar is typically the opposite of the mandibular third molars. So mesioangular is the most difficult because it's running into the back of the 7. You kind of almost have to unlock it to get it out of there to roll it out the posterior maxilla, compared to a vertical or a distoangular, which are already heading in the right direction out that posterior maxilla. So basically the ease of extraction based on angulation is best remembered as being the opposite of that of the mandible. Dealing with other impacted teeth, so certainly in the maxilla, like we mentioned, the canine is often impacted. Typically we try and save these teeth if there's space for them, and they can see an orthodontist and bring it down into occlusion. Certainly the third molars provide no benefit to the patient's ability to chew, speak, function. The canine, on the other hand, is cornerstone of that maxillary arch. It really defines that maxillary arch form. It's a highly functional tooth that we would like to preserve if possible. Rarely the tooth won't be salvageable. You'll either try and bring it down by exposing and bonding it, and it's just not moving, and eventually it needs to be extracted, or it's so far out of position or there's no space that you'll elect to extract the impacted tooth instead of furthering or even trying initially to bring that canine down. Now, that's often a judgment call between the orthodontist and the oral surgeon involved in the case, and that's going to be a case by case basis. So if the decision is made to save the tooth, we'll typically expose the tooth in conjunction with the orthodontist and bond a gold chain onto the tooth, allowing the orthodontist to put traction on the canine and bring it down. If the tooth is close to the oral cavity, we won't necessarily bond a gold chain onto it that day. We'll just simply expose it, mobilize it, make sure it's not ankylosed. And this will sometimes allow it to erupt spontaneously. If nothing else, as the gingiva heals, the orthodontist can then later put brackets on and bond the now exposed canine and pull it into the arch. Here's another example of a canine that was simply exposed but not bonded with a gold chain in hopes that it would heal in such a fashion that the would either spontaneously erupt or more likely just give the orthodontist access to put an attachment on it later after the soft tissue healed. Here you see a canine that was palatally impacted, which 85% of them are, was exposed, bonded, and pulled into the arch, as you can see in the bottom right. The canine now in a normal position, taking up a very important position in the dental arch, allowing for finishing that case in a nice class 1 canine. So how do you take out an impacted tooth? So 5 steps. You got to develop a flap. You got to achieve bone removal. You have to section the tooth. You have to take out the sections one at a time. And then you have to smoothen things up, wash it all out, and close it. So step 1, flap development. Typically it's a sulcular incision adjacent to the 6 and 7 with a distal releasing incision going over the buccal shelf. The cartoon picture shows it going a little too straight out the back for my liking. Albeit a cartoon picture, I inserted a green line in picture A and B where I would do it myself clinically. The concern is if you go too far straight out the back, typically in real people, there's no bone there. You're into that sort of sublingual space where the lingual nerve cruises along and you're putting that at significant risk of transection, neurotomesis, and numbness. So I'd rather err on the side of caution, go a little more distal buccal like I've shown in that green line, and create what I consider a 3-corner flap, with that being your release into your sulcular incision, allowing great access. C and D, I typically never do. It's an anterior release. Certainly some people will. My concern with that is if you extend that too far, you're heading right towards mental foramen. But some people will develop a little 4-corner flap with an anterior and a posterior release. But my normal would be more like an A and B. Sulcular incision, extending into release, distal buccally over that buccal shelf, keeping everything safe, but still giving you nice access to where that third molar is. Same thing, my normal would be that found in A and B with a sulcular incision, extending into a distal buccal release, as opposed to C and D where they've done an anterior release. I typically don't do that. Can't remember the last time I needed to do that for a vertical extension. So my normal would be A and B, but good to know C and D exist. A and B is just going to be much easier to put back together at the end of the procedure with a nice stitch tacked in distal to the 7 compared to C and D, which is just more time consuming to reconstruct and more likely to dehisce and not heal as well. So once you have access, step 2 is removing the overlying bone. You can use what I typically use as an 8-round burr. Here they're showing a 703 Fisher burr, which is also very acceptable. This tends to be the area that's underdone by the beginner. You really want to get good bony access down to the CEJ, around that distal buccal and mesial buccal line angles. If you can just barely see the tooth, there's no way you're going to get it out. You need to see the tooth and then some. You really got to get down to that CEJ and then extend that trough around the mesial buccal, distal buccal line angles, so that the tooth has some type of hope of ever coming out that bony hole. Sectioning the tooth, um, typically you'll want to, on a mesioangular tooth, split right down the middle. Certainly you can do what they showed here, is just take the distal aspect off the crown. In general, when you've done your bony window, expose the crown, and you're doing your vertical section and you're trying to go right down the middle, you often have to err towards the mesial aspect of what you can see to truly get the middle. If you go to what looks like the middle, you're typically only going to chip that distal half off. So that's a advanced level little pearl that anyone in first year oral surgery learns very quickly. Always err towards the mesial aspect of what you can see, simply because there's often a lot more of your impacted 8 hiding under the bone and under the distal aspect of the 7. So if you err towards the mesial, your split will end up being right in the middle, which is perfect. You get that distal crown, distal root out, leaving you with mesial crown, mesial root, which you can now roll out easily now that the distal's out of the way. So horizontal impaction, often quite daunting to the beginner, but once you get good at them, it's often quite systematic. Once again, you need good access with your flap, good bony removal, and good sectioning, and just a sound plan in your mind. So typically these will come out in 4 separate pieces you'll see on the next slide, with the crown being 2 pieces and the roots being 2 pieces. This is my mock-up of horizontal 4/8. So when you access the tooth, you want to do your bony removal down to the CEJ. In case you're wondering, this is supposed to be a horizontal 4/8. Bone removal down to the CEJ, so that you can see the whole crown, and then often a little bit even further down, just so you can see where that furcation is. And then the ultimate goal will be to remove this tooth in 4 pieces, like mentioned, 2-part crown, 2-part root. So typically my normal will be, instead of making those red lines all to completion, I'll split the tooth along its long axis. So between those 2 stars, I'll do that cut first. And then I'll go in with my 77R and make sure the 2 pieces are moving independent of one another. Assuming the tooth's fairly low and that the half of the tooth doesn't want to slide right out. Now that I know that I've had the tooth bisected between those 2 stars and I can see clearly that they're moving independent of one another, then I'll go and do we'll call it the moon line. So cut along the CEJ, and that way you're separating the crown from those 2 root segments. So now at this point you'll have piece 1, 2, 3, and 4. Sometimes I'll only do my moon line halfway down to the furcation, remove piece 1, and now I have a better view of what's remaining of the crown. Really delicately finish that cut to separate piece 2. Piece 2 is often the hardest one to get it out because it's the most inferior. It's locked in under your 7. Once you get piece 2 out of the way, you're just left with your 2 roots. You're often off to the races at this point. You can make a little purchase with your periosteal elevator, the superior aspect of part 3, pop it out, and then that leaves you with piece 4, root 4, and pop him out. So 1, 2, 3, 4. You got to systematically annihilate these guys. Distoangular, you once again need a good flap, good bony removal, and then you got to make space, because every time you touch this tooth, they say it wants to rotate distally into the ramus. So you got to do something significant, and that's either cut off a big chunk of the distal aspect of the crown, or as in this picture, just take the whole crown off, creating some space to bring those roots into. So in the mandible, you'll often be taking out the tooth in segments, which is step 4. In the maxilla, rare to have to segmentalize a tooth. Usually you can get a nice purchase on the mesial aspect and roll it out in total. Always want to give your wound a good wash. Make sure there's no sharp bony edges. If there are, deal with them now. And then nice tight closure. So here we can see real live example of partially impacted tooth 3-8. You can see a distal buccal release over the buccal shelf. Notice how it's a little more buccal instead of straight at the back. Still giving you good access to the bone around your impacted or partially impacted 8, allowing you to do a bony trough. Here you see flap development in the subperiosteal plane with the Bishop's retractor retracting the flap safely underneath it. Buccal trough is created, and typically you would have to segmentalize a tooth like this down the long axis, take out the distal aspect, followed by the mesial aspect. It appears as though this operator is trying to pop it straight out vertically with a crier, which is a reasonable approach if it comes easy. If it doesn't come easy, I would bail on this pretty quick and move to segmentalizing it. This is an example of how you would segmentalize it using tooth 4-8 as a demonstration. Vertically, nice clean slot right down to the furcation, allowing extraction of that distal segment, and then that mesial segment will come quite easily. You want to make nice clean lines with clean segments of tooth. You don't want to be crushing tooth. You don't want bits of enamel going into your wound, acting as foreign bodies and not as for infection. Either way, you want to give it a good wash out, suction things clear, make sure there's no bleeds, and then reconstruct your periodontium by putting your flap back. Typically using a plain gut 3-0, and the most important suture is the one at the distal aspect of your 7, which is the corner of your flap, and that will be a very key stitch to positioning your flap into a physiologic position, creating good attached gingiva at the distal aspect of that 7. Anytime I'm taking out third molars, certainly going to suggest to be done under procedural sedation. Tends to be much more comfortable for the patient. Typically give antibiotic prophylaxis for infection prevention and dry socket or alveolar osteitis prevention. So 2 grams of amox or 600 of clindamycin. So this is not for infective endocarditis. This is for post-op morbidity reduction. I will give steroids through the IV, typically 10 milligrams of dexamethasone, which has been shown to decrease pain and swelling post-operatively. And then I'll prescribe post-op chlorhexidine rinse that I have the patient start post-op day 1, twice a day for 14 days. And of course, post-op analgesia, typically using 600 ibuprofen every 6 hours for the next 3 days, along with a prescription for 10 tabs of Tylenol 3, instructing them to take 1 to 2 tabs every 6 hours as required for pain. Alright guys, thought I'd make a little video on extraction of impacted teeth 3-8 and 4-8. This is all this patient had. They didn't have uprights, so they were both mesioangular impacted with about a third of the root developed. So we do a distal buccal release into a sulcular incision. Get our number 9 periosteal elevator in there to develop a little flap. And then I swap out my Bishop's retractor for a Minnesota retractor. It says a finer tip on it. So we have flap development, then we have bone removal. We go for the buccal trough, so we're using our number 8 round burr, getting down to the CEJ, right up to that mesial buccal line angle, with care not to damage the 7, and then right around the distal buccal line angle, of course with care not to go too far. Perforate through the lingual cortex, damage the lingual nerve, followed by segmentalization of the tooth along the long axis. So here we're trying to get right down the middle. Like I said, you want to err towards the mesial aspect of what you can see. Get a nice even split. Try to make a nice clean slot so that you can then go in with your 77R dental elevator and finish your split, removing the distal aspect. Taking out the hemostat, check the root tip, make sure you got it. See how it looks like there's not much left, but when you go with your 77R, there's actually the entire other half, which is the same size, if not bigger than the distal aspect that we already took out. Thorough debridement with sterile saline and or sterile water. Suture with the plain gut 3-0. First one at the distal aspect of the 7. Most important suture, just to get that attached gingiva back on the distal aspect of the 7. Very important stitch. Get it down snug in behind the 7, that way the patient's not biting on the flap. Get our assistant to cut it about 5mm tails. And typically with a small flap like this, it's just the 2 sutures, so one at the distal aspect of the 7, and then one midway along our release. So I just get a nice normal size 3mm bite. I'm not plunging through into the floor mouth, bagging the lingual nerve. You want to get it down nice and snug. 2 throws one way, 1 throw the other, and then 1 throw back the original way. 5mm tails. Suction out the excessive blood, put a gauze in there, and then move on to the other side. And repeat. Here you can see we do the exact same thing. Distal buccal release over intact bone. I know there's bone there because I can feel it with my retractor. It's blanching the gingiva. So distal buccal release, sulcular incision, really making sure I haven't left any periosteum behind, so that when I go to elevate with my number 9 periosteal elevator, I can get clean down onto bone, really develop that flap in a nice clean subperiosteal fashion, taking care not to tear the flap anteriorly, making sure it's passive. Notice my retractor sitting on bone. It's not crushing the flap, it's not tugging on the flap, it's just resting on bone. So this gives me access to where I want to be. Use my number 8 round burr, exact same fashion, buccal trough. Just making sure my Minnesota is under the flap. And then back in there. Notice how the assistant is irrigating from the front, suctioning at the back, away from my number 8 round, so I can see everything that I'm doing. The normal rookie mistake is to not to do enough bone removal to allow for the tooth to come out. So you got to get down to the CEJ, say right around those line angles, with care. And then once you've gotten down to the CEJ, you've made a hole big enough for each half of this tooth to come out. That's when you start to section it. And you'll see my 8 round actually drop into the pulp chamber, which is validating. It tells you you're oriented bang on. Right there you can see it drop into the pulp chamber. So we bisect the tooth. Typically don't go 100% of the way through. Allow your 77R to do the rest of the work for you. So you might go 80% of the way through. The last 20% you crack with your 77R, and then elevate out the distal aspect with the associated root. 77R back in there. Get that mesial aspect with the mesial root out using your hemostat. Removing any remaining bits of follicular tissue. Subperiosteal lavage. You're getting under that flap, really copious lavage. Often when they come back with a subperiosteal abscess, it's right in that exact space. A little bit of bone dust or some enamel dust. Secondarily, in fact, is you want to wash that out there now. Once again, removing any of that residual follicle. Once again with care, not to crush the lingual aspects of your flap and the associated lingual nerve that could potentially be lying in there. So in and doubt, irrigate more. I want it nice and clean. And then put the flap back right where it came from. So same thing as the other side. Plain gut 3-0. Reconstructing that attached gingiva at the distal aspect of the 7. Nice 3mm bites, nice solid bites. Put your needle driver over the wound, 2 throws one way. Suck it down at the distal aspect. See how we tuck it in just behind the distal of the 7. That way the patient won't be occluding on it, won't be interfering with the healing. 5mm tails. So one at the distal aspect of the 7, and then one midway along the distal release. You can put a second if you need it, if it's sort of gaping open and you think food's going to be getting down in there, but there's some value into having it not completely watertight to allow any residual ongoing bleeding to find a way out so it's not building up in the wound. So 2 throws one way, 1 throw the other, and 1 throw back the original way, and you're done.